For 6 years on active duty from 97 until 03, and then retired from the military and was allowed to stay on. So I'm kind of a retread. So been at Wilford Hall now for 10 years, which in geriatrics kind of gives you a little bit of a benefit, because that's actually a lifetime when you're talking about a lot of our geriatric patients. And I'm proud to be here to talk to you about thyroid dysfunction in older patients. And I want to do two things. I want to have a multimedia presentation. So I've got my talk up here, but I also want to talk over here. Because I want to do two things. I want to, I have 53 slides. So, you know, it's a cruel and unusual punishment if you think about death by PowerPoint. It's an awful thing. And I know sometimes you have speakers who come up and just talk with you for a long time on stuff. I'm a geriatrician, so I take care of patients who have thyroid problems, hypothyroid, hyperthyroid, and other issues that we'll talk about. But at the same time, I want to acknowledge that you folks are a corporate body as well. And you all have patients that you take care of who have thyroid problems, and you know a lot of stuff. So I want to talk about things, but I also want to put some things up here on the board. And I want it to be participatory and informal. So, because that's a good way to have people not fall asleep. Noontime, dark room, that's the substrates are right there. So, but it's my pleasure to be here and to talk with you today. So here's what we're going to talk about today. So we're going to talk about normal thyroid structure and function. We're going to talk about hyperthyroid and hypothyroid in the young and old. But we're also going to talk a little bit about the differences between young people and old people. So as you guys know, those of you who are geriatricians, those of you who may be rotating on, anybody rotating on the geriatric service? So, okay, sounds good. So we see a lot of very different things. That's kind of the joy of geriatrics, because there's a lot of different things that we see. So, you know, old people don't present like young people. There's an awful lot of difference between old people and young people, but it's so much fun because it's a big challenge. I even brought my own markers.
And typical presentation of disease.
Oh, right, exactly. Different presentation of disease. You have to treat it a little differently. So, normal thyroid and structure and function. Let's talk about else. Here's what else we're going to talk about. We're going to talk about, this is something I know you folks encounter every day, because we do all the time. In fact, I was precepting down in the internal medicine resident room yesterday, precepting for resident clinic, and we came upon exactly as this, and I had a whole stack of articles, and I was able to pull out the article. Well, that's a cool, to be able to pull out an article and say, you know, this is an issue that I was just reading on just today, so I was able to give the resident an issue. So you scored some cool points. We're going to talk about subclinical thyroid disorders. Subclinical hypothyroid, subclinical hyperthyroid. So maybe you do some tests and some kind of really don't look like the patient's hypo or hyperthyroid, what do you do in a situation like that? It's kind of like, why did I order that test? Now I got to do something about it. So, thyroid cancers, we'll talk about that a little bit right at the end. William Rehnquist had thyroid cancer, thyroid anaplastic carcinoma, bad cancer. And we're going to talk also, I mean, you can't talk about a geriatric topic without talking about ethics. You know, it's a very important thing. Should we measure? Shouldn't we measure? Should we test? Shouldn't we test? You know, what do you think about when you talk about older people and maybe people who might need, do you really want to treat them? Do you really want to treat that 95-year-old lady in the nursing home for hypothyroidism? Maybe, maybe not. So we'll talk about that. Ethics. Thyroid disease is very common. So you look right up at the top 5, hyperthyroidism. This is the percent of patients with each one of these endocrinopathies who are greater than 60 years old. And there's a lot of them. So hyperthyroidism, about 15% of the folks who have hyperthyroidism are over 60. And just a caveat, the closer I get to the geriatric years, the older the geriatric is. So I don't really count 60 as a geriatric patient. You know, sometimes you'll see in reading, you know, patients over 55. Oh, okay, that's good. I mean, over 65. Hypothyroidism, lots of folks, maybe about a third of patients who have hypothyroidism are over 60. So interesting. Papillary thyroid carcinoma, follicular anaplastic thyroid carcinoma. Only about 1% of the thyroid cancers are anaplastic, but boy, that's a bad one too to have, because these people just don't do well. That's what Justice Rehnquist had. And we talk about the other ones down here. Questions up to this point? Let's talk about normal thyroid. As you guys know, a little bow tie, you know, it's kind of sitting right up here. Left and right lobe of the thyroid. It's kind of tough sometimes to palpate thyroid nodules. Lots of people have them, and the older that you get, the more thyroid nodules that you have. Thyroid hormones, T3 and T4. So thyroid hormone is 2 molecules of tyrosine. Actually, 1 molecule of tyrosine with 2 little antennas on here. Iodine, another molecule, iodine, tyrosine and tyrosine, T4, or low tech, T3. Well, actually, one of these, I can't tell you which one, one of these cleaves off T3. Reverse T3. So T4 circulates in the blood, not very active. Little bit of activity, not much. T3, the active portion. Just clip that one off, and it's actually working. Reverse T3, clip the other side off, has no metabolic activity at all. So this is what we read. So this is T4. How does T4 travel in the bloodstream? Right, protein bound. So it's bound to proteins. Those of you who are geriatricians, thinking in a geriatric manner, you kind of think, oh my gosh. A lot of times our geriatric patients may not have a whole lot of protein. The older you get, you know, maybe your protein's a little bit less. So that might be something. So protein bound is active or inactive? Inactive, correct. So T4 bound to protein, inactive. Free T4, kind of the active portion. This T4 is clipped not in the bloodstream, but by different organs outside of the thyroid. to make active hormone. This is what we measure, though. We measure free T4 and TSH, thyroid stimulating hormone. I have a cartoon of that. So again, T3, T4 contains iodine. We're going to talk about, so what's some cardiac medicine that we use right now that uses a lot of iodine? Amiodarone, that's right, exactly. So amiodarone is going to come into play in a little while. We're going to talk about that. How else do our older people get a big influx of iodine? What do? We say, oh gosh, you're breathing a little bit hard. Maybe we need to do angiogram, something like that. Or maybe contrast, exactly. So contrast material can give you a big influx of iodine. So that's another way that we can kind of have our patients kind of change their thyroid mechanics a little bit. It's protein bound. There's a couple different kinds of proteins that there's thyroid binding globulin TBG that's in the blood. You can measure this if you want, and in some thyroid states you can. About 75% of thyroid hormone is bound to TBG. Also albumin, and then there's also transthyretin, which also is present in the blood. Protein bound. Okay, feedback loops. This is kind of a cool thing. In TSH we talked about. So feedback loops. So lots of ways. I mean, you guys know about feedback loops. Can I see? Okay, great. So feedback loops here. Here's the thyroid right here. It's very, very elementary. So those of you who have seen this ad nauseum, I apologize, just to make sure that we're all on the same wavelength. So the hypothalamus stimulates the pituitary with thyroid releasing hormone to TSH, thyroid stimulating hormone, to say to the thyroid, hey, gotta make some thyroid. So T3 and T4 made by the thyroid. Down here in the liver, it's conjugated. Get rid of it into the GI tract. Thyroid feeds back on the hypothalamus, on the pituitary, to say, all right, got enough out there, slow it down. So feedback loops, very important. This is what we measure right here, TSH, T3, T4. If you're wondering, is your thyroid overactive or underactive because of pituitary? Do you have an adenoma, or do you have something else going on that? You know, we can measure thyroid releasing hormone as well, and hypothalamic disease. Triiodothyronine enters the cell through a receptor, goes into the nucleus, and turns it on, and says, all right, you need to metabolize protein, you need to make some more DNA. Kind of works right here in the nucleus. And it kind of turns the cell on to metabolize fat, protein, carbohydrate. In newborns, helps them grow. So if you have a newborn that's born hypothyroid, that's not a good thing. So a lot of other receptors. But the main one I want to just key in on is T3, turning on the nucleus to start the cell. So if this cell is not stimulated adequately, if you're low thyroid, your body's real slow. If you're high thyroid, your body's real fast. That's kind of as simple as we can get it as far as thyroid activity. Questions up to now? Anybody any questions? Okay, good. You guys are doing good. So tests, TSH, free T4, thyroid autoantibodies, radioactive iodine uptake. We'll talk about those all in just a few minutes. On page 2. So let's talk a little bit about hypothyroidism. So differential diagnosis of hypothyroidism. Two different things you see. Autoimmune, Hashimoto's thyroiditis. So an antibody against the thyroid. Kind of slows things down. Radioactive iodine treatment. So a lot of times our old people have some of these things that are going on. They have some other things as well. But it's not uncommon that you see a patient taking Synthroid, and you say, why are you taking Synthroid? And they can say, well, you know, 40 years ago I had a thyroid nodule, or I had something going on with my thyroid, and they ablated it. They gave me radioactive iodine, and ever since I need to take thyroid hormone. So radioactive iodine treatment, thyroid surgery, maybe radiation therapy. Maybe they had head and neck cancer, and then they had radiation to throat cancer sometimes. They have radiation to this area, which completely fibrosed their thyroid, so they have to take thyroid medication. You guys right on iodine-containing drugs, amiodarone, lithium is a big one that can really change your thyroid activity. And hypothalamic pituitary disorders, a little higher up. So, signs and symptoms of hypothyroidism for everyone. So, we talked a few minutes ago that old people are very different than young people. Old people present differently than younger people. So, this is what younger people would look like when they're weak. They're lethargic. Really hard to get out of bed in the morning. They're constipated. They have dry skin. They're losing their hair. They're cold all the time. Their face is a little puffy. Their voice deepens, and they have carpal tunnel. Think about your old people. Does this sound like your normal presenting symptoms of old people? How are you doing today? Oh gosh, I'm constipated. Gosh, I don't have any energy. I'm just weak as can be. So if that was an old person, you might think, oh, let's check your thyroid. Later on, we'll talk about, oh my gosh, why did I check my thyroid, or that thyroid? Now what do I do? But this is it. So how do you, what's thyroid disease look like in old people? Do they present symptoms of thyroid disease in an old person?
What's on the differential depression?
Excellent, very good. So it sounds, maybe depression, you say, oh gosh. So what would they say if they, what would be some words that they'd say if it was depression?
Like either hypersomnia, again, the energy.
Sleep all the time, very good. All the time. No energy, I'm really tired. Hard to get out of bed, very good. What else?
They could have cognition.
Cognition, right. I can't remember anything. You know, that can come back to depression, you know, pseudo-dementia or dementia. Or, so, you know, when somebody comes on in and say, I'm having a hard time remembering things, what kind of tests do you get? What do you get when somebody comes on in and says, gee, I can't remember anything? DSH, yeah. Yeah, what else?
B12.
Yeah, what else?
Complete metabolic panel.
Sure. Chem 7, Chem 10. What else? CBC, very good. What else? RPR, very good, yeah. RPR. The thyroid's in there too. So it's in my memory. You know, there's so many different things. We have this dream that maybe we can treat your memory. Oh, I have some bad news for you. It's Alzheimer's disease. I have some good news for you. It's depression, or it's thyroid, or it's B12. We're going to give you some medicine. And when they come back, do they say, gee, I feel great, now I can think again? No, it's real hard to treat memory problems. I've had one patient in my career who I was able to improve their memory, giving them some thyroid. So it doesn't happen very often, but boy, when it does, you feel great. You say, there's hope. We can do something for you. What else? What would be some other complaints that someone might, an older person might bring to you that might suggest thyroid disease? Pardon me? Constipation, very good. Yeah. Everything's kind of slowing down. Let's see what else we had on here. So this is, okay, this is old people. Asymptomatic. They might come to you and say nothing, but they might have thyroid disease. So very important. Mental slowing, physical slowing, depression, neuropathies. That's very important. You know, I'm having pain or numbness in my legs. Not really what you'd say, aha, that's thyroid disease. Anemia, hyponatremia, lipids. You know. So if you're working somebody up for cholesterol problems, maybe check their lipids, check their TSH as well. Let's see, arthritis, paresthesias, gait disturbance, slow. So we kind of talked about those. So real bad hypothyroid, slowing down just almost to zero, myxedema. This is a bad thing. This is a medical emergency. So this is a geriatric emergency. And it's this guy right here. So has nothing. He has puffy eyes. He has expressionless face. He's just, his coarse hair, maybe some weight gain, just really right on down there. So myxedema, bad thing. ICU admission. You know, this guy needs some big time help. Subclinical hypothyroid. This is a big deal because this is something that you guys see all the time. In fact, probably a whole lot more often than you'd see with thyroid hypothyroidism. So you see a slightly abnormal TSH. So, you know, if 1.5 to 6 is your normal TSH, this might be 7. 7.2. You think, oh my gosh, normal T4. Maybe symptoms, maybe not. So this may be somebody who came on in that had a little bit of mental slowing or said, gee doc, I'm really tired. Or, you know, I'm sleeping a lot, I'm constipated. Oh, let's just get a thyroid, let's get a TSH on you. And then your lab says, wow, TSH abnormal. Our lab goes ahead and orders a free T4 along with that. So maybe symptoms, maybe not. So what do you do with that? What do you do with that? What do you do?
Follow it.
Observe.
I'm sorry?
Wait,
Yeah, you could recheck.
wait, most from waiting for something.
Yeah, you could do that. Go to see your patient. How's my patient look? Does my patient look hypothyroid? I mean, you know, we always say, never treat a number. Treat a patient. So if their T4 is okay, their TSH a little bit abnormal, you can take a look and see, did we do this before? Have they done that before? Are they taking thyroid hormone? Maybe are they not taking enough? And we don't know. We don't really know, but see if they have symptoms, because that comes into the differential. We'll talk a little bit more about that. So is that normal aging or is it disease? And again, we're not positive. Over the years, does your thyroid have a tendency to slow down a little bit? Are you going to develop thyroid disease at some time in the future? Maybe. Do you treat it or not? Do you bump up their synthroid? You bump it up a little bit. So, how did we get here? Why did we check a thyroid in the first place? Well, maybe they came with something else. The ACP says if you have a suspicion, they said test women. They don't really talk too much about should you test men or not. The American Association of Family Practice, American Association of Clinical Endocrinologists says screen women periodically, because it can be, we talked a few minutes ago, it can be asymptomatic. So we might want to just check that. So the epidemiology, this happens. The Framingham study said TSH 5 to 10, a little bit, 14.4% of the folks on the Framingham study had that. Maybe or maybe not disease. Greater than 10, still 5.9%. Greater than 10 is that's probably a 2 times elevation. That's a pretty big deal. Wickham checked thyroid antibodies, anti-thyroglobulin, thyroid peroxidase, and said in their test, the folks who were over 6 had 60% of them had thyroid antibodies, maybe saying, gee, maybe you have a subclinical type of a thyroid disorder. Greater than 10, 80% of them had. And what do we know about autoantibodies in old people?
They're very non-specific.
Mm-hmm.
There's a immunological, there are a lot of changes in immunological system with aging.
Oh, sure.
So, I wonder if we count them as specific in older patients.
Right. Old people make autoantibodies.
Yeah.
Are they always clinically significant? No, not really. If you check a rheumatoid factor on an old person, more times than not, you're going to get a positive. You'll probably get just the lowest titer, and you say, oh, now what do I do with it? So kind of like this. If you check a SED rate on an old person, you're probably going to have a little higher than the corresponding one for a younger person. So, but just the fact that you have anti-thyroid antibodies there sort of suggests that there might be some type of a disease process, and if not right now, maybe in the future. Questions up to this point?
Does the guideline says that we have to test asymptomatic women?
It says, and they're really nebulous. They don't really say every so often you should check, because we don't have an awful lot of evidence base on this. But periodically check a woman for asymptomatic thyroid disorder. So when they do their annual physical and you check lipids, if their lipids are abnormal, it's also a consideration. Maybe they have some thyroid disease that's
But
involved.
without having any red flags, are we screening patients for hypothyroid? Is that a guideline?
The American Academy of Family Practice does say from time to time, but again, screen women for it, but it doesn't say absolutely. Not like your every, not like hypertension or lipids.
Mm-hmm.
So it's a little bit kind of up to the doc, kind of whatever you feel.
So the U.S. Preventive Task Force does not recommend screening for asymptomatic.
Well, the American,
Yes.
let's see, the Task Force for Preventive Medicine doesn't have a recommendation. Progressive hypothyroidism, again, the evidence is really not there. Studies have shown anywhere from 1 to 20% may, depends on how you classify hypothyroidism, maybe 7% per year, especially if you have a TSH, well, in this study, TSH greater than 6, and thyroid antibodies. And I have all these studies. I didn't list them on here, but I certainly will be happy to furnish those for you. So, the effects. So if you're a good doc and you say, I want to really take care of my patients, so I don't want them to be fatigued or have dry skin or cold intolerance, constipation. So, if they show that they have some of these, you might want to go ahead and consider treating. If they've got muscle cramps, that may help. At least see how they're doing. If they have dyslipidemia, everybody has coronary disease, cognitive impairment, so probably about 80% of your old people are going to fall into this category, or those that you see in the clinic regularly. So, it may be a consideration to treat. So the current treatment recommendations, if a TSH is greater than 10, treat with a little bit of Synthroid, little levothyroxine. If it's 5 to 10 and they have symptoms, or if you can demonstrate thyroid antibodies, go ahead and treat, or follow and recheck them in again, as you said a little bit ago.
But how often do we do?
Otherwise, and you still, it's very reasonable to follow as well. And again, it depends on your clinical suspicions. So treatment of hypothyroidism, levothyroxine, mixed edema goes on into the hospital, and then just follow up. Check out about a month when we're out. How much time do we have? Do we have until 1 or?
1:15.
1:15. Okay, 12:15 to 1:15 sounds good. Okay. We're still going to have plenty of time for questions. Questions up to this point on hypothyroidism, thyroid issues in old people. Anything else? Treatment until now? Okay, good. We still have a lot more to go. Hyperthyroidism. You know, hyperthyroidism for everybody, a little less common than hypothyroidism. In young people, not too much, 0.2 to 2%. And typically this is Graves' disease. This may be an autoantibody to that TSH receptor, kind of turns the thyroid on. So, you know, we saw up here where, you know, the pituitary sends a signal down to the thyroid saying, you know, turn on and start making thyroid hormone. Well, this is an autoantibody that kind of does the same thing. It sort of acts like TSH to turn the thyroid on and to make a lot of antibody. There's a lot of reasons why you may have, you know, we have clinical hyperthyroidism, we have subclinical hyperthyroidism in older people. This, you can have excessive thyroid replacement, Graves' disease, thyroiditis. This probably should be just hyperthyroidism. We're going to talk about subclinical in a few minutes, but if this is just regular old garden variety of hyperthyroidism caused by thyroiditis, maybe you have a goiter, maybe there's a lot of iodine intake. And we talked a few minutes ago about excessive iodine intake, not so much if you're taking in a lot of iodine, but you're giving it amiodarone, lithium, contrast material. It's very important. We do a lot of things to our old people that in the name of goodness that actually can result in other diseases coming on. So very, very important. That's why you have to take care of your old people with kid gloves. But it's good. Signs and symptoms of hyperthyroidism in everyone. So just kind of think about the basics. Your thyroid is just going crazy, metabolizing everywhere. All your cells are revved up, working real hard. The nucleus is being of your cells is being told metabolize like crazy, and you have tremor, you have tachycardia. You know, it may go into AFib, palpitations, nervous, you can't sit down. Not the constipation, but more like diarrhea, heat intolerance. You can't really diagnose that in Texas here in the summertime. Weight loss despite increased appetite. It's almost like you're on steroids. You're eating everything you can possibly do. Exophthalmos. I have a picture of exophthalmos. Boy, that's that gets you out. Hard to miss that. Protein, you don't really know exactly what happens, but there's a protein that builds up in the back of the eye and kind of pushes it forward. I have one patient who has this hyperthyroidism, and they've ablated his thyroid, and he has exophthalmos, and they've actually done, our ophthalmologists have done surgery to bring his eyes back on in. Horrible, horrible situation. He's doing well. They're doing the best they can, but this is very, very scary. You know, you can almost think that she almost looks like alarmed, like this is a patient who would be, have hyperthyroidism. And actually look at her neck, look at her thyroid area. I mean, it's huge. This lady probably has a goiter, thyroiditis. She has a very, very prominent thyroid. So hyperthyroid in the elderly, a little different, and again, asymptomatic. That's the joy of geriatrics, the joy of taking care of people who can't tell you things, don't have presentations, but still expect you to figure out what the disease is. And it's great. It's a wonderful challenge.
That's the geriatrician detectives.
That's right. CSI all over again. So they're tachycardic, they're weight loss. Sometimes they have anorexia. Sometimes they just eat everything. They go to the buffet and fatigue and apathy, or muscle weakness, a thyroid myopathy. So very interesting, very exciting. So there's some tests. You know, thyroid antibody. and you may be able to demonstrate these. You know, a little different type of a thyroid antibody than you'd see in Hashimoto's. Hashimoto's, you know, it's going to slow your thyroid down. This is more of this. Autoantibodies work a little bit differently on the thyroid receptor to increase it up. So, but very, very important. Check antibodies. Subclinical hyperthyroidism, though, just a little tiny bit of hyperthyroid. What do you do? We'll talk about treatment in just a minute, but it's a normal free T4 and a low or undetectable TSH, less than 0.01 or 0.1, way on down. But their free T4 is normal. What do you do? You see it. A little bit more in men than subclinical hypothyroid. Women 6.3, men 5.5. But again, it depends on how you classify it. Other studies say 2.1 to 6% have subclinical hyperthyroid fall into this category. That's a lot of folks. So if you think about how many people you see in a week, you know, does it progress? Again, 1.5 to 13%. That's horrible statistics within 1 year. So that gets your attention, though. Maybe not, maybe it does. Why would you, well, what, if you didn't treat it, if you didn't follow it, we've shown that these people can have an impaired quality of life. They get AFib, and it's actually increased the risk of AFib up 3 times. So it's a big deal. Ventricular function, so it works on the cardiac, it works on your heart, cardiac function, bone loss. So osteoporosis. We know that hyperthyroid or over replacement of hypothyroidism can lead to osteoporosis. So bone loss, increased mortality, to die earlier. So very, very concerning. Something that we really want to gets our attention and want to watch. So how do you treat? Different ways to treat. So if somebody comes on in, they're tachycardic, they're really going a mile a minute, so you want to slow their heart rate down a little bit. Beta blockers, propranolol can help a little bit. Actually, any of the beta blockers are going to slow it on down. I-131 will ablate your thyroid. And in old people, you don't have an awful lot of choices. You have surgery, medicines, methimazole or propylthiouracil uracil. But if you're looking for an old person, I-131 is typically the type of treatment that we give because it's quick and it works. And eventually, you're probably going to have to you're going to make them hypothyroid, from hyperthyroid down to hypo. So you're probably going to have to replace their synthroid, their levothyroxine. So, but again, it's down the line. And somebody like Our Lady with exophthalmos, she probably needs surgery. She probably has something big deal going on. Surgery, if you can't swallow, you swallow down and it doesn't go down. Massive thyroid. Here's another one that kind of gets us sick. Euthyroid flips around a little bit. Normal TSH, maybe a little bit low or a little bit high, but the free T4 is low. And these are people who are in the hospital with non-thyroidal illness. So someone who might be in the ICU, somebody who might be, it might take a while for them to get off the vent, and you're kind of thinking, gee, should I check their thyroid? Do they have thyroid problems? They hypothyroid. And you find out that they're in this situation. Somebody with acute and big deal acute disease. What do you do? Sick euthyroid. We see it. Oops, I didn't put a reason why. What do you do?
You don't check the TSH.
You wait. Yeah, that's right. Yeah, it's true. Should you follow that? Yeah, you follow it. Do you treat it? No, you don't. You don't treat it. You don't give them more levothyroxine. You just wait because we don't know. There could be almost invariably these improve, and if they don't improve when you see them in follow-up, then do the right thing. Treat. So thyroid nodules kind of coming down to the end here. Questions up to this point? Okay, good. You guys are doing well. I appreciate your participation. Thyroid nodules. Prevalence increases with age, and good. We're talking about old people over 70, not old people over 60 or 55. 80% have greater than one. We've been able to show this in autopsy studies. We find that there's a lot of people, a lot of older people have thyroid nodules, but if they're less than a centimeter, you can't palpate them. I'm kind of thyroid nodule challenged because I have a tough time picking very many thyroids. I do meticulous thyroid exams, but I have a hard time. I don't know. Anybody else here? Anybody great at picking up thyroid nodules? Yeah, probably. It's tough. It's a challenge. Hashimoto's, you probably, hypothyroid. You might see a firm thyroid. Probably not painful. Multiple little tiny nodules around. May go away with treatment. Anaplastic carcinoma. This is worrisome. This is where you examine the thyroid of somebody. They may come in and say, I got this thing in my neck, and it's really, I'm wondering what it was. I mean, old people check themselves out all the time. So they'll come on in and they'll say, oh, I got this thing right here. It's different. And you feel it, and it's stony hard or fixed, and automatically you think, uh-oh, large stony hard mass. So what do? You check thyroid functions and see what's going on with the thyroid. If they look a little hypothyroid, you can do an ultrasound to see where it is and how big it is, but the ultrasound's really not going to tell you anything. So the easiest test, in fact, I'm recertifying in Geriatrics this month, and one of the review questions that you guys will see if you're a geriatric fellow is, what do you do with a thyroid nodule? And the answer is, you poke it, and you just see if you can see anything in there. It's quick, inexpensive, high yield for a diagnosis, unless you want to also, you can do a radioactive iodine, I-123, not the I-131. Reach for the other bottle, the I-123. That's to test and see. And that kind of tells, is your thyroid gland, do you have a thyroiditis? Is your gland highly functional or not? And you can take a look at nodules. The I-123, and it's a question of warm or cold nodules. The cold nodules are the scary ones. The warm nodules, they're functioning. It's kind of normal thyroid tissue. So, check a thyroid TSH and a free T4 and see how they're doing. If you have one with a low TSH, looks like it's producing a lot of thyroid hormone, that's a hot nodule if you look at it. I have a couple pictures of some thyroid scans. If it's a cold nodule, doesn't uptake, that's scary. That's almost like non-thyroid. It's a different type of a cell, not a thyroid, not a functioning thyroid. Here's a normal thyroid scan. You can see the left and right lobes and the isthmus. This is a warm, auto-functioning thyroid nodule. So it's probably pumping out lots and lots of thyroid hormone. This is okay. It's a good thing to see. That's a bad thing. Anybody see that? So that's a cold thyroid nodule. Those cells are something different. They're not great thyroid cells. So, cancer. So what do you do with a thyroid nodule? If it's benign, if you stick it and it looks like it's just benign tissue, you can follow that. You can try to suppress it with levothyroxine. But if it's cancer, then you need to send them to surgery, and they're going to probably want to not only do surgery, but radio ablation in case there's been any metastases anywhere else. Thyroid cancer, kind of coming up to the end here. Oh, we're doing good on time. Different types. Papillary thyroid cancer, the most common. 81% of all the thyroid cancers are papillary thyroid. Anaplastic, that's the one that Justice Rehnquist had. That's a bad one. That's the one that we see most often in old people. Fortunately, it's only 1% of all the thyroid cancers, so that's good. Hurdle cell cancer and medullary cancers are still in there as well, but papillary, 81%. So here's our summary, our last slide. Thyroid can overfunction or underfunction in disease. So it can overfunction a whole lot, hyperthyroid. It can overfunction a little bit, subclinical hyperthyroidism. It can underfunction a little bit, subclinical hypothyroid, and underfunction a whole lot, hypothyroidism, classic hypothyroidism. So it's important to correlate your numbers with your patients, see what they look like. It's important to follow this and have a good high index of suspicion for thyroid abnormalities in your old patients, because we see that, and there's treatment for it, and they get better. Always keep a high level of suspicion. I think that's my last slide. So on your handout, I have my email address, and I certainly would be happy to help you with any questions that you might have about not only thyroid, but any other geriatric issues that come on up. I can help you if you have any questions of where did you find certain data. It'd be my pleasure to help you out with that, and anything you like. Yes?
What's your opinion on like generic versus name brand products?
Wow, boy, isn't that a great question. I don't know if there's enough data out there. I've heard different things, but I've not myself seen an awful lot of data on that. But
I think there used to be a big difference, but now the manufacturer of the generic is much closer to the brand. There's really no difference. So I just tell my patients.
What we always see is that as long as you stay on either
Same
generic or the
generic.
brand, you're fine. So when teachers come to the pharmacy or whatever, we always ask them to make sure they're still on the brand, or if they're not switching back and forth, because you still have the FDA 80 to 125% within the limit to be approved for a generic medication. So that's what we always tell them, to stay on the same
Okay.
thing.
so we used to have something called Armor Thyroid, desiccated thyroid. Do you remember that, Dr. Royal?
Yeah.
Patients loved it because they it made them hyperthyroid. Like one bottle would be a little tiny bit of thyroid, another bottle would be, it was cow thyroid. They chopped it all up and they gave it to them, and they got a little bit of a high from their thyroid medicine. So if you try to say, you know, we don't use that anymore, I'm going to switch you over to something else, into regular thyroid. Oh no, that doesn't work, Dr. Kruger. I don't want that. I want my other stuff. So, but we don't stock it in our pharmacy. I don't know if the FDA even allows it anymore.
They do.
Oh, do they? Okay. Other questions?
Can you tell us about hepatitis C and antithyroid antibodies?
Oh my gosh, that's a great. You know, I don't know the answer to that.
Because
Yeah.
herpes simplex codes the human acetylcholine receptor, and in theory could cause autoantibodies to acetylcholine receptors, and it's been implicated in Alzheimer's. And I'm just wondering if much is known about other viral autoantibody associations. I know that hepatitis C is associated with thyroid illness.
Wow, that's a great question. I don't know. That's the more things that we're finding out, though, about autoantibodies, it just becomes more and more intriguing. Other questions? Yes.
I mean, when I started practicing, I definitely used to treat all of my subclinical hypothyroids, 8, and I would make a statement that they have symptoms. I mean, I feel like every elderly person, if you reach deep enough into their review systems, you can find a symptom.
Mm-hmm.
But, I was intrigued last year when this Norwegian study came out that showed that subclinical hypothyroid actually had a mortality benefit in those over 85 and the oldest of the old. So now I'm a little bit, has that changed at all, your practice, and people over 85 or over 80, are you less likely to treat them now? Because now I sort of feel like I'm hedging a little more about treatment.
Yeah, and it's so difficult because we have nothing evidence-based in the older population. Studies are just so are terrible in the older population. But I agree with you. I did read about the hypothyroidism being a little bit better. So your metabolism's a little slower, It's almost like lower calories. You know, if you can kind of slow your body down with, don't give your body so much substrate, kind of keep it down a little bit. So it's great point. Well, great. Well, I appreciate you guys. This is a wonderful opportunity. Thank you so much for asking me to come, and it's my pleasure to talk with you. Great. Thank you very much. Thanks for the participation. Yeah, I appreciate it.